Hi everyone, my name is Julia Mayetta. We are so pleased that you all could join us today for our 5th lecture in the 12-week didactic series. This series brings you lectures from experts in the field covering different topics each week. The Neuropsychology Didactic Series from Know Neuropsychology was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities for the international neuropsychology community. We would like to thank our sponsors for their financial support for this series, including APA's Committee for Early Career Psychologists and the American Psychological Association of Graduate Students, or APAGS, the Association of Postdoctoral Programs in Clinical Neuropsychology, the International Neuropsychological Society, and the Society for Clinical Neuropsychology, or APA's Division 40. Before we start, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own and do not reflect the official endorsement of any institution or organization. Questions for our speakers? It's a box on the lower left of your screen that's next to the chat box. We will address questions submitted to the speakers during the last 10 minutes of today's talk, and a recording of today's lecture will be provided this week on our website. Now it is my pleasure to introduce Dr. Victor Del Bene and Chad Gaudet for today's lecture on neuropsychological assessment of aging and cognitively impaired physicians. Victor Del Bene is a clinical neuropsychologist and faculty member of the Department of Neurology at the University of Alabama at Birmingham School of Medicine, where he conducts evaluations for a diverse clinical population spanning movement disorders, epilepsy, dementia syndromes, and other neuropsychiatric disorders. He is currently involved in research related to epilepsy, aging, dementia, and Parkinson's disease. Dr. Del Bene earned his PhD from Yeshiva University, completed his internship at UAB, and completed his postdoctoral training at Johns Hopkins University School of Medicine. Dr. Del Bene supervises doctoral students and interns at UAB, and he is the immediate past chair of the NAN Student and Postdoctoral Resident Committee and the immediate past programming officer for Division 40's Association of Neuropsychology Students in Training and Trainees, or ANST. Charles, or Chad Gaudet, is currently a predoctoral neuropsychology intern at the VA Boston Healthcare System. His research and clinical interests broadly include methodological enhancements for interpreting serial neurocognitive data, concussion detection and management, cognitive function in psychiatric syndromes, and early detection of neurodegenerative disorders. Clinical interests also include lifespan neuropsychological assessment. So without further ado, I'd like to turn it over to Dr. Del Bene and Chad.
All right, so thank you all for coming out. As you can see, we do not have any financial disclosures and we do not have any conflicts of interest. And so in terms of the objectives of what we hope to accomplish over the next 40 to 45 minutes, Dr. Del Bene and I are going to try to provide a brief overview on the following topics. So we're going to discuss issues pertaining to aging, and more specifically, its relevance to the United States physician population. Additionally, we're going to try to provide an overview of research to date that's examined the relationship between neurocognitive function and physician performance. And then lastly, given what can be discerned from research and current policy, some important practical, clinical, and ethical considerations in the neurocognitive assessment of physicians. So I like to start this presentation with the following quote from the Wall Street Journal. I believe it succinctly captures the overarching challenge related to neurocognitive assessment in this population. How does the similarities response relate to physician performance? Or stated differently, the broader implication relates to what is the external validity of our procedures and methods for evaluating this population? I think that, so to speak, is our hook for tuning into the forthcoming slides. And I'd encourage you to keep this question at the forefront of your mind throughout the presentation. So as we all know, in the general population, the majority of estimates point to significant growth of older Americans. Consequently, we predict issues related to healthy cognitive aging will continue to gain prominence. And as neuropsychologists and aspiring neuropsychologists, there'll be ample opportunities to contribute both relative to advancing our understanding of mechanisms and potential interventions to promote healthy aging. Broadly, it's relatively well established that subtle declines can be anticipated across several cognitive domains. Most notably, we expect to observe declines in processing speed, attention on complex tasks, memory recall, and verbal fluency. Additionally, relative to anatomical changes, healthy older adults also begin to demonstrate changes in hippocampal volume, increased beta amyloid deposition, reduced synaptic density, as well as reductions in white matter volume and integrity. To varying extents, these changes manifest on cognitive testing, hence we have a role. Additionally, with increased age comes the risk of dementia syndromes, movement disorders, stroke and other vascular factors, and systemic illnesses that impact the central nervous system. So unfortunately, an MD does not also confer protection against the adverse effects of aging, and physicians are susceptible to cognitive decline as well. Now, given physicians' level of educational attainment, coupled with the cognitively taxing nature of their work, we would expect this population to possess a high degree of cognitive reserve. While cognitive reserve is likely to mitigate observable decline to some extent, the literature would also suggest that this population may be at an increased risk for precipitous decline when cognitive reserve is exhausted. Now, regarding how declines or impairments in domains most commonly implicated might manifest in physicians, we offer some hypothetical examples at the bottom of this slide. So as you can see, the costs related to surgical, prescriptive, and communication errors could be devastating. I don't know about you, but if I was on an operating table, I certainly wouldn't want a surgeon with a processing speed deficit. Or if I have a prescriber with a poor memory, I wouldn't want to end up with contraindicated medications on my medication regimen. These are just some examples of potential places where cognitive decrements could interfere with physician performance and then have an adverse effect on public health. So what's the potential magnitude of this issue facing the US? So as the bar graph illustrates, nearly 1 in 2 physicians practicing in the US as of 2013 were over the age of 55. This trend is only expected to continue, as can be seen on the following slide. Then additionally, consider the proportion of physicians in this age bracket nearly doubled in the past 30 years. So as can be seen on the chart on the left, physician age. So as of 2016, approximately 1 in 3 physicians practicing in the US were age 60 or older. Consider that in the context of what we presented earlier regarding the risk for cognitive decline. Now, alternatively, and admittedly, the chart on the right is a bit shoehorned in here, but I wanted to call attention to another critical factor. That is the interaction between cultural factors and neurocognitive assessment. Although data related to whether a physician was born in the US were unavailable, I selected medical school location as a proxy. And as you can see, approximately 1 in 4 physicians practicing in the US received their medical education from a school outside of the US. Given what we know regarding the sensitivity of many of our measures to culturally mediated factors, it is of critical importance, in my opinion, that we advance our understanding of these issues in general and in physicians in particular. So what data do we have regarding how cognitive impairment affects physician performance? So in 1999, a study suggested cognitive impairment was the most common cause of medically adverse effects. Interestingly, physician self-report may not be the most reliable indicator of potential cognitive impairment. As such, simple reliance on physicians to voluntarily remove themselves from practice when they notice cognitive impairment is unlikely to result in adequate patient protection. So if we don't implement specific structures to protect public health from physicians who could potentially go on practicing impaired, it could become a very significant risk, or it may already be. So research has also suggested that physicians, to the extent they are aware of any issues, are unlikely to voluntarily disclose these problems. The second bullet point from a survey of surgeons published in 2009 reveals some other disconcerting data related to this medical specialty, given their reluctance to adjust their practices in the presence of cognitive changes. Specifically, 32% of surgeons over the age of 55 continue to operate despite noticing impairments in cognition. And then lastly, in that bottom bullet point, just as physicians do not appear well suited to self-disclosure of cognitive dysfunction, they do not appear much better at self-policing, considering their reluctance to report colleagues. Another slide I wanted to shoehorn in relates to a topic not specific to aging, but highly relevant to physician populations. That is substance use. Data suggest physicians are at higher risk of substance use, and the relationship between substance use and cognitive impairment is well established. Moreover, as highlighted on the prior slides, the lower likelihood of physicians either independently seeking treatment or being reported by a colleague support a case for broader neurocognitive assessment in this population. It's not entirely clear that it should be limited to folks at a certain age, given that substance use affects us across the lifespan. I believe Dr. Del Bene will touch on this point later. So what then are medical organizations doing? So they've become increasingly attuned to such issues and appear prepared to implement formal policies to protect both physicians and the public from adverse events related to cognitive impairment in physicians. Specifically, the American Medical Association has called for formal competency testing. Additionally, the American College of Surgeons have called for voluntary and confidential neurocognitive assessments to establish a baseline. And then more recently, in 2019, the Society of Surgical Chairs recommended mandatory cognitive and psychomotor testing beginning at age 65. At a state level, California has published explicit guidelines to facilitate physician screening. So the document cited on this slide suggested that some commonly used cognitive screens might be suitable for this purpose. However, a gaping hole in the research literature was identified regarding the evidence base for cognitive screening in this population, or back to this matter of external validity, which we touched on at the outset. So this raises a critical issue related to validity, which is increasingly, which a larger body of research is increasingly trying to better elucidate. So praising the literature. So I apologize in advance if this slide appears overly elementary. However, I think it might serve as a useful guide when you encounter new literature in this area. Namely, upon entering search terms related to physicians and neurocognitive function, you'll encounter a multitude of commentaries, an increasingly growing number of reviews, but only a handful of empirical studies. And this was an issue I wrestled with when I first began researching this topic, is that you probably won't come across a shortage of articles, but when you look for actual evidence and data, it's much harder to come by. And so those boxes along the top are meant to illustrate loosely buckets that these articles will fall into. And then I think when you identify an article that falls into that research bucket, there are some specific questions that you want to have in mind as you proceed through that article. The first being the nature of the sample. So is it a referred or non-referred sample? And by referred, I mean, were the physicians under review referred for a competency evaluation, which appears to be the most common sample reviewed in these studies. And what that means generally is someone or some body has already identified some concern in this physician. Hence, the individual is already referred. So we're not proactively identifying cognitive impairment in these samples. At this point, though, I also want to explicitly emphasize and preemptively state that any critiques of these studies are largely beyond the control of the researchers. I think for data collection purposes, and for reasons Dr. Del Bene will elaborate on later, this is an extremely difficult population to study. Now, conversely, in those referred versus non-referred samples, a positive that comes from that is that you can then infer from their cognitive performance how it relates to the nature of the errors that may have necessitated the referral in the first place. So we're working kind of backwards there, in that we're seeing, okay, these folks are demonstrating errors. Now what does their cognitive performance look like? In terms of that second row, we also want to be aware of the measures, and specifically which normative or reference groups were used for interpretation. And then additionally, if cutoff scores were used, were the cutoff scores age adjusted? This is going to relate to another point that's going to arise in the literature, which is what should you use for normative data? And when you identify an appropriate sample, should you use an age adjustment, or should there be a performance-based cutoff? Meaning, amongst the sample of physicians, should we just aggregate all the data and use the general mean and standard deviation to determine whether performance is normal or abnormal, or should that be adjusted for, well, you're a 60-year-old physician versus you're a 30-year-old physician? And that issue, I still think, remains unsettled. And then in the third row, this issue underlying validation, which is how do scores correspond to actual physician performance? And in this fashion, I'm talking about longitudinally. So when we have cognitive data, are they predictive of future cognitive performance, which I think is the ultimate question in this literature. And then additionally, were cultural factors considered? So as illustrated earlier, about 1 in 4 physicians receive their medical education outside of the US. So as such, we might expect it to be important to understand how this could affect performance on tests that are typically developed in the US. So as I noted, there's an increasing number of reviews, one of which was just fortunately published, I think, within the past month. And I found it highlighted many of the issues unique to physician assessment, and it relates these issues to cognitive screens that many of us are familiar with. So specifically, what I think at least is the central table in this manuscript provides a standing of the MoCA, R-bands, SLUMS, microcog, and ANAM on a variety of variables of particular import to physician populations. So specifically, this table provides for whether the screens offer normative data unique to physicians. Is the normative data, or are they adjusted for age and education? What are the classification accuracy statistics for some of these screens? Whether there's a potential for ceiling effects on these screens, which we would think is of particular relevance to this population, and the reliability data, which would speak to potential longitudinal use. So I'd strongly encourage individuals and attendees of this lecture to use this review as a starting point in preparing to delve into the literature. Now for the research studies. So what do we know? So Turnbull published a series of studies in 2000 and 2005 that included a sample of physicians referred for competency assessments. And as I mentioned earlier, these are folks who have already had concerns raised about their performance. In the first study, about 1 in 3 demonstrated impairments on neuropsychological testing. And then on the second study, which looked more explicitly at the issue of using age-adjusted versus performance-based norms, so that issue of, do we just use a general cutoff for everyone, or do we adjust it for age? They found that more than half demonstrated impairments when using performance-based norms. So it's fair to infer that that's going to be the more conservative criterion. The other study discussed on this slide from Perry and Korean administered one of the more extensive neuropsychological batteries that consisted of many of the tests that we're probably familiar with in common everyday practice. They too looked at a sample of referred physicians. In this case, it was 148. Their results indicated that about half of the physicians were obtaining abnormal scores on between 1 in 9 and 1 of 6 tests. Now, given what we know about normal rates of abnormal performance, it's not quite clear how to interpret these results. But given its status as one of the more nascent studies in the area, it's certainly an important one to consider. And it also provides useful data for some commonly used measures that we see in everyday practice. For this second group of studies that are somewhat more recent, The first one is at least the first that I encountered to include a group of non-referred physicians. So these were physicians that volunteered for the studies in which there weren't any notable concerns expressed by supervisors or patients. This study used the microcog, which is included in the review that we discussed 2 slides earlier. And this measure is a computerized test that has been designed specifically for use amongst physicians. I believe it was developed by an insurance company. And in this study, moderate to large effect sizes were identified primarily on measures purported to appraise processing speed, accuracy, and proficiency. So this further advances the notion that cognitive deficits may underlie referrals amongst identified physicians. And I apologize, I don't know how to pronounce the last name of the author for the second study, but I'll try. So the Kataria study published in 2014 is interesting, as it was conducted in Great Britain. And in this referred sample of physicians across the lifespan, they used the Addenbrooke cognitive exam. And of those 109 physicians, 22 scored below the cutoff. However, what I found most interesting was that 21 of the 22 physicians obtained their medical credentials outside of Europe. It goes on to suggest that English was not the primary language of these physicians. So I think this further underscores the critical need to understand and appreciate cultural effects on testing. And this is our last summary slide for the research. And on it, or within it, includes 2 of the more recent contributions to the literature. So the Williams study in 2018 included 4 unique samples. It included healthy airline pilots, non-referred physicians, and physicians referred for specific concerns. So interestingly, the study found approximately a 2% false positive rate, meaning that about 2% of healthy or non-referred physicians were obtaining abnormal results, and what appears to be a significant difference between those referred for behavioral concerns versus those referred for medical and technical concerns. So as you can see, we're starting to get more specificity in the nature of physician performance deficits as they relate to cognitive testing. And this final paper included in our review was published in JAMA this past January, and it received a fair amount of coverage in the press. It was conducted through the Yale New Haven Hospital system and with healthcare providers exclusively over the age of 70. So as can be seen, about 1 in 10 demonstrated impairments on a neuropsychological battery. Unfortunately, this study was published as a performance review, and it did not report specific tests that were administered or performance data. And then, so what can we conclude from our brief overview of the literature? So first, about 1/3 to 2/3 of physicians identified for referral also demonstrate cognitive impairments, meaning when colleagues or patients observe behaviors that are concerning to the point that they're willing to report them, which we know is somewhat unlikely, at least amongst fellow physicians, we're often able to identify cognitive dysfunction. To my knowledge, 2 studies directly compare performance between referred and non-referred physicians on cognitive testing. Both of these studies use the same measure, the microcog, and thus we need to diversify our understanding of performance on other measures. And then lastly, and related to that pesky question of external validity, the relationship between cognitive testing and physician performance is limited. For example, the longitudinal study that identifies the association between a standard deviation decline on verbal memory and a 10-fold increased risk for prescription error has not yet been conducted. And with that, I'll turn it over to Dr. Del Bene.
So I'm going to go over a brief study that I did back on my postdoc. This was published back January 2020, so a few months ago. So it's pretty hot off the presses. What we tried to do is we tried to look at physicians that were referred clinically compared to a normative group, because that was something that's really lacking in the literature. There's not many studies that have a physician reference group, and we had access to that. So I'll go through the study now. So in our study, we had 2 groups. We had a control group, which were healthy, successfully practicing board-certified urologists, a sample of 39. these urologists, they were tested under contract with their practice management to establish neuropsychological baselines in case they were to have a stroke, a TBI, or some form of cognitive decline later on. And what we mean by successful here is that they were practicing independently without any complaints from patients, any concerns from peers, and no indication that they were having cognitive problems or work-related issues. The other group is the clinically referred physicians. We had a sample of 30, and they came to us through two pipelines. They were either referred by their personal health care providers, or they were referred administratively, either from a state physician health program, state board of physicians, or from their clinical service chiefs, or hospital administrators. So either someone brought a complaint to the board, someone brought a complaint to a superior in a hospital, or someone on their service team noticed that the physician was having some difficulty. Breaking it down, we have a sample. Our sample is largely men, and I think a big part of this has to do with the fact that these were older physicians, on average 48 and 64 years old. So these weren't the physicians who are on residency or internship currently. These were physicians, many of them educated 20, 30 years ago when things were a little bit different and it was mostly a male-dominated industry. And I'd imagine if we did the study in 5 years or 10 years, that these numbers would likely be more balanced relative to our current sample. Of the community physicians, of course, 100% are urologists and 100% have no neurologic, psychiatric disorders or suspected cognitive impairment. Of the clinically referred, we had a nice distribution. 20% were family medicine or internal medicine, 23% psychiatry, 7%, meaning one person, was urology, and then other would indicate oncology, surgery, pediatrics, things like that. Sorry about that. These were the tests that were given. So everyone who came in, they all received a comprehensive neuropsychological assessment, so clinical interview, plus review of records, including imaging, and any pending litigation or any pending board complaints. And then they did a neuropsychological assessment. These were the core tests. Sometimes additional tests would be given, as well as measures of mood and personality and psychiatric symptoms like the Frisbee and the PAI and the SEL90 and the BEX. But for this study, we really just focused on the cognitive and motor measures. So to start off, we had the Wonderlic Personnel Test. This is a measure that's often used in IO psychology and in human resource departments, but it gives you a measure of IQ. So it's not intentionally meant to be an IQ test. It's really meant to be a general cognitive test of cognitive ability that can be used to see where people place within a profession. But you could get an estimated IQ, and the reason why this was selected over something like the WACE was that it takes about 12 minutes to administer, and at the upfront, we weren't too concerned about IQ relative to other tests and other cognitive domains. And so that's going to be a scaled score or standard score that we provide for you. But the rest of the tests will be shown in raw score format or Z-score transformations. So we had simple digit modalities, and we had both the written and oral portions of that. Then we had group pegboard test, dominant hand to non-dominant hand, so bilateral. We looked at the Hopkins, the HLT. We looked at the delayed raw score, and the BVMT, also the delayed recall raw score. We then looked at the DCAPS trail making test, specifically trial number 4, the number of letter sequencing score, and the DCAPS tower test, the raw score achievement for that. And we didn't look at every DCAPS score. We didn't look at everything that you could get from an HLT because we wanted to minimize the number of comparisons we were doing so that we weren't getting potentially false positive findings. So our goal was to divide these 30 clinically referred physicians into 2 subgroups. One of them would be the impaired group, the group that we know definitively has rather pronounced cognitive deficits. And we didn't know what to call the other group, so we settled on ambiguous. And we picked ambiguous because these were people who were referred because someone noticed something wasn't quite right with their performance, but they didn't meet our criteria for impairment, and so therefore they're labeled at this moment as ambiguous. So to break this down, what we did is we took the raw score performances and we transformed them to z-scores using the distribution of the urology control group. So all the scores from this point forward will be looked at as relative to the urology control group. To determine the optimal criterion for categorizing physicians as impaired or ambiguous, we had to meet several criterion here. First, they must score at or below the 5th percentile on either 3, 4, 5, or 6 of the 9 neuropsychological measures. And we were going to test out which of these cutoff points were ideal. And at least one of these scores had to be free of motor demands, which means one of them has to be the Wonderlic IQ score, the HPLT delayed recall score, or the oral symbol digit performance. And the reason for this is we didn't want someone who maybe has Parkinson's and has a lot of motor symptoms getting impaired scores that would prevent them from working, saying that they're impaired, they can't go back to work, but maybe they're a psychotherapist, and it doesn't matter if they have tremor, it doesn't matter if they have dystonia, if they're sitting down and their verbal skills are fluent and their comprehension's fine and their memory is great. So we want at least one test to have a cognitive component to it. We ran a simulation model, a Monte Carlo simulation, where we put all 9 test scores in. We said we had 9 tests. We said that they were likely to be moderately correlated. I think it was a 0.3 or 0.4 correlation that we used. And we wanted to see what the output would be for a cutoff of 3, 4, 5, or 6 scores as a cutoff. And we wanted ideally to select that a cutoff would have the probability of impaired scores occurring less than 1% by chance, give us good separation of physicians who are still working from those who are no longer working, and separate the physicians with no neurodegenerative conditions from those without no neurodegenerative conditions. So here we have the breakdown of whether we use 3, 4, 5, or 6 tests, and a cutoff of 5 or more scores at or below the 5th percentile gave us the best breakdown and met our requirements that we laid out. The caveat here is that it is a small sample size, and so if we had double or triple the sample, it's possible that a cutoff of 4 would be fine, but we wanted also to err on the side of caution, and we're dealing with people's livelihoods here, and that there's a lot of implications if we say someone cannot practice medicine. So we felt that if someone has 5 or more scores that are impaired at or below the 5th percentile, that there's a good likelihood that this is not due to chance alone, this is not just normal intra-individual variability, and that there's something going on that we need to be mindful of. And so if you use 5 or more scores at this criterion, you find that the probability of occurring by chance is just 0.55%. It gives us good separation on the diagnostic criterion as well as the employment criterion. So we went with that for our study. And so when we break that down, we have our 39 reference community physicians. We then have 14 patients in the impaired group and 16 in the ambiguous group. All these scores here are raw scores with the exception of the Wonderlic IQ, which is in red. And what you'll see is the IQ for community physicians who are cognitively intact is about 130. And the ambiguous group is about 120, so a little bit of a decline, but still very high. Whereas the impaired group, their IQ on this measure is 105, so squarely average. And that's a pretty substantial decline. The rest of the data, it makes a little bit more sense to view this when we transform it to z-scores and plot it out. So here we have the reference group being 0, that line right across the board at the top. And then we have the impaired group in the dotted dashed lines below. and the ambiguous group. And it's not surprising that either group is performing below the control group. All these people were referred. So that's not shocking. That wasn't surprising us. But what we see with this criterion is that there's nice separation between those who are ambiguous and those that are impaired on basically every test with the exception of DCAF's tower. Again, small sample size, so one or two people could really change the results. And it would be nice if we had a larger sample size, but this is kind of what we had to work with here. But with that said, we do have some very nice large effect sizes and some big separation there. So looking at the breakdown of the sample, we find that we have 13 men per group, one female in the impaired group, one woman in the ambiguous group. And there's an age difference. And this is an important caveat here. We didn't want to control for age statistically because a lot of the changes that we would see would be due to age, could be due to age or age-related diseases, and we may be factoring out or covariating out the effect that we were looking at. And also, as Chad mentioned earlier, there's going to be issues of cognitive decline with aging, and what's the best metric to measure decline in this population? If you use age-based norms and someone's in the average range, that's fantastic. But if you have someone who's 80 years old, who's a physician or surgeon, who gets an average score or even high average score compared to the normal population on group pegboard, but is in the borderline range compared to other physicians and surgeons, is that someone you necessarily want operating on you? Maybe not. And so age is a tricky thing in the sample that if you correct for age, using age-based norms, you may be missing some signs of decline, but at the same time, age is an important factor that we do need to consider. And I'm not quite sure how to do both at the same time at this point. It's something that we're kind of actively debating and trying to figure out as we go through this. When you look at the primary disorders in the impaired group, 43% had a known neurologic condition, such as Parkinson's disease. 14% had a known psychiatric condition, and in this case, it was things such as bipolar disorder. And then 43% had a suspected cognitive disorder. They were diagnosed by the neuropsychologist as having mild cognitive impairment or possible Alzheimer's disease. In the ambiguous group, 25% had a neurologic condition. This was usually Parkinson's, and that they didn't have much of a cognitive sequela accompanying it, just more the motor symptoms. The psychiatric conditions tended to be more things like anxiety and depression. The suspected cognitive decline was mild cognitive impairment with an unclear etiology. And then the unknown other would be things like a suspected learning disability in the case of a physician who is a foreign-born physician who's trained overseas. And there's a lot of cultural issues that came with that assessment, substance use issues, head injuries, things like that. So as you see, there's a little bit more heterogeneity in the ambiguous group here. When we considered the work status, we have the impaired group on the left and the ambiguous group on the right. And when we look at the impaired group, we see that between 5 and 10% of the impaired physicians were working either at full or reduced capacity, but the vast majority had either suspended their license or had it temporarily disabled or revoked, or they retired due to age or disability. Whereas when you look at the ambiguous group, the vast majority were either working at full or reduced capacity, or they temporarily suspended their practice pending the results of their assessment. Very few of them had given up or had their license revoked, and no one retired due to age or disability. So some main points from the findings from the study. So based on the sample and our specifications, 47% of referred physicians were impaired. And this is consistent with prior estimates that found about 20 to 60% of physicians who are referred by the board of medical examiners have some level of cognitive impairment. The mean IQ score in the impaired group was solidly average. It was approximately 2 standard deviations lower than both of the other groups. Again, age was not considered by our grouping approach, but the impaired group was significantly older. And this is consistent with greater prevalence of cognitive decline among the elderly and the higher likelihood of neurodegenerative illness. Senior physicians are at increased risk for medical errors and poor outcomes. And a review of 62 studies showed that physician knowledge and quality of care is inversely related to the number of years since they graduated from medical school. And older surgeons have statistically significant worse outcomes than younger surgeons, even if there's no difference on cognitive testing. So age is definitely something that's really important one to consider when seeing physicians for these referrals. So again, most patients in our impaired group, subgroup had mild cognitive impairment, a dementia syndrome, or Parkinson's disease. And the ambiguous group is more heterogeneous, made up of MCI, mood disorders, medical conditions, substance use, a suspected learning disability. So limitations, as we touched upon earlier, it's a small sample size, which reduces the types of analyses we could do and the amount of things that we could covary for statistically. It would be great if we had double or triple the sample size. I'd love to see if a lot of these findings hold up. What we did have also was a limitation was that the physicians were all, the referred physicians or control physicians were all urologists. And the pros with this is that urologists are clinical in their work, and they also do procedural, they also have a procedural specialty to their skill set. So they do procedures and they do clinical work, which makes it a little bit more generalizable than other, clinically based groups of physicians. But the cons with this, it lacks representation by their specialties. So the skills that a psychiatrist or an internal medicine doctor requires may be very different from what a surgeon or radiologist or ER doctor requires. If you're a radiologist, you really have to have fantastic visuospatial abilities. If you're a surgeon, you have to have great visuospatial abilities, memory, processing speed. Whereas if you're a psychiatrist, maybe your motor speed can be a little slow. Maybe it doesn't matter so much if your visuospatial abilities have declined a bit. As long as you have great memory, your verbal fluency is intact, your comprehension's intact, and your attention is fine. So there may be some nuance and some differences across the specialties that we need to consider as well. Again, our sample is comprised largely of men. One would hope that race and ethnicity and sex and gender don't affect the skills of a physician, but this is not something that's been empirically studied, and we want to make sure that when we're seeing patients or referred physicians, we want to make sure that we're not misattributing a low score to something that's not necessarily related to an illness, maybe is due to some cultural factor or some sex-based difference that we need to be mindful of. So if we're making our recommendations in the most sound, culturally appropriate manner and diverse, with considerations for diversity as best we can, so that we're not maybe saying someone shouldn't practice medicine when really it's more of a multicultural issue that we didn't account for. Another limitation with this is it's a retrospective study design. This was based on people that were referred clinically, and we tried to remain blinded. So Dr. Brandt knew who was who and what the outcomes were, but when you're putting this together, I should add that I didn't know what the diagnosis was. I didn't know why they were referred. It was just based solely on a actuarial approach. So we tried to make it as objective as possible in that sense, but really it would be fantastic if we could do a prospective study where we get normative data and baseline data on physicians and then track them over time and try to link this with adjudication outcomes, whether it's at a court level or a medical board level, as well as other medical outcomes such as mortality rates and patient complaints or things like that. So some future directions, we need better norms. So the Williams et al. Paper did report some normative data using the microcog. And that was fantastic, but not everyone uses the microcog, and the microcog is a screener. So if you want to do more of a comprehensive neuropsychological assessment, you may find that you only have age-based norms to compare them to. or in this case, the paper that I published back in January, but the reference group is only 39 physicians, so it's really small. So I think as a field, we need to work towards having a better normative database of physicians, because as you can see with this little schematic mock-up here, if the general population has a mean of 100 on a test, we may find that physicians on that test have a mean of 109, or maybe it's 112, but we need to have a better idea of where those physicians are starting off at a group level. And then we need longitudinal assessments. So assume Dr. Jane Doe undergoes cognitive assessment, and her results are compared to a healthy normative sample from the general population, and her scores are in the average range. From that alone, you couldn't necessarily diagnose mild cognitive impairment or a cognitive disorder, but for her, maybe that's a change. You know, maybe her baseline was above average, and in the high average to superior range, and she has had substantial cognitive decline. What do you do with that in that case? So if you're using the wrong norms, you may miss a change if you're comparing them to just the general public, and if you don't have their own baseline as well. So it'd be really important moving forward if hospitals could do something like get a baseline on every physician at some point. This way we know where they were in case they have a stroke, in case they have a traumatic brain injury, in case they have a medical complication, in case they're showing signs of Alzheimer's disease, so that we know where they were at one point, and now we can see where they've gone following the illness or the injury or the progression of insidious symptoms. So returning back to the quote Chad started with, that was from the Wall Street Journal, the one thing that this physician hits upon here is the ecological validity as well as the face validity of the test that we have. And so for someone who's not a neuropsychologist, they may view our testing as irrelevant. And that could lead to a contentious moment with the patient or the referred physician who's trying actively to protect their livelihood, who doesn't see any utility in what we're doing, or maybe challenging what we're doing. And I think it's really important, if you're going to be doing this work, to have an idea that this could happen. They could question the validity of the entire assessment, and that you should really be mindful of that and have a good, thoughtful, and empathic response, understanding that they're going through a lot of stress and a lot of concern that they have about losing their ability to practice medicine and maybe giving up their career, and maybe something that they've done for the entirety of their adult life. And there's a lot of existential concerns that come with that. So just something to be mindful of. So moving forward, clinical neuropsychology is likely going to occupy a prominent position in the assessment of physicians, especially with the aging physician population. And this may not always be in the context of a board report complaint, for example. They may not be referred by the board, and it may not be a competency to return to work type eval. It may just be that this person was a physician and they've had a stroke, or this person was a physician and we're concerned about Alzheimer's disease. And so just knowing the literature would help you get an idea of how to assess these patients appropriately. As Chad touched upon, there's important cultural considerations. If there's a growing percentage of foreign-born physicians practicing in the United States, we need to make sure that we have a better grasp on multicultural neuropsychology, and we need to know that what the limitations of our tests are, especially in such high-functioning individuals, and where we, what the bounds of our assessments can really get at with those patients. We may not be able to be as direct or as confident in our findings given many cultural concerns with certain tests. And that speaks to the issues of external validity, assuming population-specific norms are used, so physicians being compared to physicians. How do you interpret a score falling one standard deviation below physician reference norms, but still within the normal range for a general population reference norm? And this is not just for physicians, but this is true really for any individual who's high premorbid intellect with a high level of cognitive reserve. That this could be lawyers, scientists, engineers, corporate CEOs, people that are very intellectually based. and have a high baseline intellect, that maybe they're below other people in their group, but compared to the general public, they're doing really well. And you don't have baseline data on that person to show how much they've fallen from baseline levels. And so it's something to keep in mind when working with high IQ and high achieving individuals who are so far to the right on the distribution. And what about physicians with substandard or lower than expected scores on testing who are objectively performing well on the job? This maybe doesn't come up in the case of a board referral, but let's say you're trying to collect normative data and you get a physician who volunteers to be in a study and they do poorly on several tests, and it's beyond normal intra-individual variability at that point. That objectively there's no problems with their performance and that they're doing well at work. But what do you do in that case if they're having some cognitive difficulties on testing? And that's part of why prospective research is very difficult in this group, is that many physicians are fearful that something will flag on a research study, and they are not very keen on participating in prospective research. Again, linking this was very helpful. So this came out about early March, and there's a news article that Yale New Haven Hospital is being sued over aging clinician assessment policy. And so this is just something to keep in mind, that as this moves forward, there's going to be pushback from various groups, people saying that it is a sign of ageism and that it's not fair and that people who aren't having problems shouldn't be assessed. But there's some other areas where this is going on, where pilots, for example, are mandated to get assessments around the age of 65 every 2 years or so. And this is the battery test that the pilots have to get. You get additional tests, but this is the core battery. And they're mandated by age to get evaluated if they want to maintain their pilot license. How do I go back, Eddie? Thanks. So the other thing is, in the United States, in the United Kingdom, surgeons with the National Health Service must stop operating at age 65 and retire by 70. India, Japan, China, Ireland, and Finland also have mandatory retirement ages for surgeons. And this one may run afoul of the mandatory retirement age of the Age Discrimination Employment Act, although that act does have a qualification saying that if age does interfere with the ability to perform the job safely and effectively, that may not hold up in court. But any firm age cutoff would prevent many competent doctors from practicing medicine. And so taking a firm cutoff, once you hit 65, you have to retire, likely is not the best approach. It would further exacerbate the physician shortage in the United States. However, many of these healthcare services, the mandatory testing that hospitals are requiring has been held up in American courts in the past. So if hospitals do decide to take this approach, there is some legal precedent for that. And so one recommendation based on everything we described is that having periodic neuropsychological screening for sensory, perceptual, motor, and cognitive abilities in all older physicians, in addition to fitness for duty evaluations for physicians suspected of impairment, is consistent with the position of the American Medical Association, as well as the American College of Surgeons. Maybe if you want to get baseline testing on everyone when they're young, that may be one approach. There's multiple ways of doing it, and I think the field has to come to a consensus on what's the best approach, and it may be a hospital by hospital approach. But I think at some point, getting baseline data on everyone will be really helpful at making sure that everything's being evaluated properly. And neuropsychologists engaged in this clinical work should stay within the bounds of their expertise, know the pertinent laws, the state medical guidelines, but don't play lawyer. Don't try to be a lawyer with this. Just really focus on describing the observed clinical presentation and cognitive profile in the context of their medical and psychiatric history, and really just have a keen eye about the normative reference groups, the demographic composition of them, and how this may affect inter-test score comparisons. So here just are some of our references, the various papers that we cited, and you'll be able to get these on the website later if you watch the video. And please join us again next week. Dr. Catherine Bingham will be discussing research on mild cognitive impairment. And I'd like to thank the rest of the neuropsychology group. And we're welcome to take any questions. I know we're towards the end of time, so I apologize for that.
Thank you so much, Dr. Del Bene and Chad, for that wonderful presentation. Being mindful of time, I just want to make sure that we do allow some time for questions. How much longer are you both willing to stay with us or able to stay with us today?
I can stay for a bit. I'm just working from home, so.
Until I get a really hard one.
All righty. Sounds good. Thank you. For the first question we have is for Dr. Del Bene, specifically about his study, but then also broader across the literature. Was there any way that you controlled for familiarity with any of the cognitive measures across the physicians, or are there ways that you've seen in the literature for accounting for previous exposure to a given assessment, for example, a MoCA?
Right, and I think I saw another question regarding the familiarity with the MoCA when presenting. So I'll address that first. In the Garrett review paper that just came out, while they talked about the MoCA and how that could be used, from my recollection, they said try not to give the MoCA. A limitation of the MoCA is that there's familiarity with that measure. And so if you're going to do a screener, something like a microcog would probably be better than a MoCA. The same is true of the R-bands. They maybe don't have familiarity with the R-bands, but that's only going to be age-based norms, and there's no physician-based norms for that yet. So I think if you can avoid the R-bands and the MoCA and focus on something like a microcog for screening, you'll get a better outcome that's less biased potentially from either past exposure or age-based norms and how that affects cutoffs. In terms of psychiatrists and patients, they went through a whole comprehensive neuropsychological assessment with us. And so if there were any any patients that said that they need tests, that would have been an issue that was discussed. But to my knowledge, some of the data collection began before I started my postdoc, but I'm not aware of any patients in our study that knew about the HVLT or knew about the DCAF Stroop or not Stroop, Tower test or BVMT, and what the stimuli were like and how that could be used to help their performance. I think if you're going to see these patients, though, it's always fair to ask if they're familiar with neuropsychological test measures, and if so, which ones. And then you could rule out, including a certain test, maybe swap out a HVLT with a CVLT, for example. And so I hope that covers that question.
Yes, thank you. The next question are, what are both of your thoughts about recommendations for if a physician is not frankly impaired or demented? How might you mitigate risk in the workplace or make accommodations or recommendations in the absence of frank impairment?
I really think that has a lot to do with the nature of the referral question. So if you're getting a referral from the state board, seeing if does this person have impairment, yes or no, then you're not the patient. I should say the referred physician is not actually your client. The client is the board, and your job is just to say cognitive impairment, yay or nay, and if so, then the board will decide whether they can practice medicine or not. If you're seeing a physician who's coming to you on their own volition, who was referred by their own physician, then it's very much going to be like a regular clinical assessment, and you could probably have more leeway, I would say, with those recommendations. Julia, was there a question about specific recommendations that I missed?
Not specific recommendations necessarily, but might you make recommendations for accommodations.
All right. Yeah, I think that's fair to do if it's appropriate for the case. And again, if it was not referred by the board, if the patient came in saying, let's say they had a TBI from a motor vehicle accident, and they're noticing they have a hard time remembering details from when they saw a patient earlier in the day, when they go back to chart in their office, you could easily recommend to them strategies on how to, recall things later on, like taking notes down throughout the day, maybe breaking up the day so that you have less patients in the morning and you have some time in the afternoon to do some charting before you have another batch of patients. You could probably strategize with them on how to improve that workflow. I think that's fair.
Alrighty, next question is related to similarity, or would you expect similar results across physician subgroups? For example, depending on medical specialty or field complexity. So would you expect a cardiologist or a neurologist or an OBGYN, et cetera, to reflect similarly across?
I'm sorry, can you repeat that first part? You kind of broke up on my end.
Oh, I'm sorry. Would you expect similar results across physician subgroups depending on medical specialty or field complexity?
And Chad, you can weigh in on this after I'm done. At this point, I don't have any evidence to say that there would be a difference, but I guess in theory, you could say that someone who's a radiologist maybe has a different skill set. Maybe they chose radiology, that kind of profession that spoke to their strengths, and the psychiatrist maybe chose the profession that spoke to their strengths. So maybe there'd be some innate, group differences that you could see possibly. But at this point, I don't think there's any good evidence one way or the other to say so. But I think we would see that if we got group norms. We may find that we don't need group norms, but there's no evidence at this point saying one way or the other.
That's my impression as well. I think it's largely an inferential exercise right now, and it could represent a useful stratification criterion. But as of now, I'm not quite clear on what the evidence is to divide by specialty.
Okay, next question is, what do you see as the most typical referral question in regards to capacity for certain activities?
I've not seen any of these cases clinically, so I do not have a response to that question. I don't know if Victor has anything.
Can you repeat that, Julia?
Yeah. What is the most typical referral question for physicians in regards to capacity evaluation?
I mean, I don't know if there's a typical one that, at least there's not one that I've seen on average. Like, usually it's a question about cognitive abilities interfering with their ability to perform medicine. But someone could have cognitive decline because they had a stroke. Someone could have cognitive decline because they have a psychiatric condition or a substance abuse problem. So the referral tends to be about cognition as well as maybe psychiatric symptoms and how that interferes with their ability to safely practice medicine. But at the end of the day, I don't know if there's kind of a template or an average a prototypical referral. I think it's going to vary from case to case.
Okay. Last question for today, I think. Maybe we'll take two. First is specifically for Dr. Del Bene regarding your study. Were the referred and control samples matched for demographic factors such as age, sex, and practice specialty? If not, was there any concern with using urology reference groups as normals? Or can you speak a little bit more to that?
I think I sort of addressed it, but I'll talk a little bit more about that. We didn't control for age, again, because we wanted to try to develop practice or skill-based norms rather than age-based norms, because we felt that if someone was of a certain age but performed just as well as younger physicians, that was more meaningful than if a physician did well compared to a 70-year-old peer who was a physician, but not as well as a 30-year-old physician and their, let's say, a surgeon, because that could have some implications for the patient. But I think moving forward, when we have larger sample sizes, it would be really nice to try to control more for age and stratify just to see if there's patterns that emerge that can be really helpful for data interpretation. We didn't intentionally stratify by sex, but the breakdown was that we had 13 men in the impaired group, 13 women in the ambiguous, 13 men in both the ambiguous and impaired group, 1 woman in the impaired group, and 3 women in the ambiguous group. So it wasn't a direct, tightly controlled study in that regard, but we did see that the sex breakdown was fairly comparable. As for using just urologists, that's a limitation and a strength, I think, depending on how you look at it. The limitation is that if there are differences across specialties, we won't see that because urology is just, they're the only people in the reference group at this point. We don't have any evidence to say that that would truly be the case. But I think that's something that we need to be mindful of moving forward, and why it would be nice to have specialty-based norms to at least rule that out as a possibility. The plus side with urology versus, say, the control group was internal medicine doctors. Well, the urologists, they have both the clinical practice and they also have a procedural component to their practice. So that makes it a little bit more generalizable, but only marginally. So it is a limitation, but unfortunately, it was kind of the best we were able to get at the moment. And I think this really is the hard part with this research, getting physicians who are healthy and performing well at their jobs to sign up for a prospective study to test their cognition, just for the sake of helping out science when, 1, they're busy, and 2, the concern of what happens if something gets detected, what does that mean for my career, really makes it hard to set up a prospective study as well as a normative study and really to get much larger sample size. It's not impossible, but I think it's going to be much more tricky to do that.
All right, last question. We got a couple of chats about broader kind of ethical and legal considerations for this group. If either of you know about the current policies of the American Medical Association, the AMA, if they have any recommendations for screening as far as like age-specific screening or things of that nature. There was also another comment brought up about a current lawsuit about mandated evaluations within the United States based on age. Do you have any thoughts about those as a closing?
Yeah, so I'm seeing Kelly's comment about the AMA policy. What we cited was a position statement that it was more of a recommendation, or that they were taking this approach that physicians should do this. And I think it was more of an aspirational recommendation. I agree with Kelly's comment. The question is that, I haven't seen anything saying that it's policy and it's nothing that's mandated yet. And I'd imagine it is very controversial within AMA and medicine in general, because you're going to have people that see it as something that's beneficial to protect physicians, protect hospitals, and to protect patients. But I can also see plenty of other people saying, well, if I'm not having problems, why do I need to go through the ringer? Why do I need to prove that I could practice medicine when nothing's wrong with me? Why can't this happen once there's an issue? And so I could see both sides of the argument, and I could see how people would feel on both sides. I think these organizations taking this approach and really trying to make a statement that, a position paper that this should occur they're trying to, I guess, lead the way and start the discussion. But I'd imagine that, whether it's the AMA or any other medical organization, they're not going to come out with any policy anytime soon, because it is very controversial. And I think it's going to be really left up to the hospitals to make their own decision at this point.
Alrighty, well, thank you so much, Dr. Del Bene and Chad, for being with us today, and check back with us next week for Dr. Bangen's talk on research and mild cognitive impairment. Thank you so much, everyone.